We're going to go ahead and get started with today's webinar. My name is Larissa DeLuna with the American Heart Association, and welcome to the American Heart Association Southwest Affiliates webinar focused on 12-lead interpretation and STEMI identification. The American Association is proud to offer a suite of quality improvement programs that can help you advance further and faster and for ever better quality. For more information about programs, visit www.heart.org/quality. Before we get today, I'd like to go over a few housekeeping items. To avoid background noise, all of your lines have been placed on mute. If you have questions during the webinar, feel free to use *6 to unmute your line or the question and answer panel in WebEx. All notes and slides will be sent to attendees within 1 week of today's webinar. Also posting a recording of today's webinar on heart.org/SWA quality. So to hear from Ben Leonard, the American Heart Association Quality and System Improvement Director for the state of Wyoming. Ben in EMS for 20 years, working in a variety of rural settings as a fire paramedic, flight and paramedic in South Dakota and Wyoming. Ben his appointment with the American Heart Association as an EMS Director for the Mission Lifeline Wyoming area in August of 2012. So at this time, I'm going to turn it over to Ben. I hear you, Ben.
There you go. That's,
there we go.
*6 wasn't working very good there for a minute for some reason. Sure. Well, thank you very much for the introduction. And as Larissa talked about, we are working on presenting a year with 12-lead STEM identification and recognition. We was asked to talk about this class. We had a group of volunteers in South Dakota actually put this together, various resources to roll out as an education program for the grant fund initiatives that were in South Dakota, and then we followed with the Wyoming project. The lot of both of the areas we supply the EMT basic provider. They did not have a whole lot of exposure to the 12-lead acquisition and utilization. Even in Wyoming, we actually had to go through legislative changes to allow them to do 12 leads. So we thought it would be a good idea to just throw this out as an offer for some 12 education. It's going to start off pretty basic. We do this review of the heart, and as well as what our treatment goals for our patients that have a STEMI. We'll go over 12 lead acquisition practices, some techniques to make sure that you have a good acquisition of that tracing. And get into kind of the STEMI identification and localization of the way it puts out into, or the way it presents on the monitor itself. So, and I apologize, it's kind of a blurry picture, but the heart is supplied the basically 3 big blood vessels. You have the right coronary artery, the left coronary, then it's branched off. The left is off to the circumflex and left anterior descending. When we look at heart attacks, obviously, and so we look at these vessels as well as other ones that are not named on this graphic, but with the blockages that occur, we'll see the changes on that EKG if it shows up as a STEMI. The other part that we want to look at, and that's such an amazing organ. I talked that we have 2 different systems: mechanical system, we have an electrical system in the heart. The electrical system here, obviously, and it is represented by the green tracing here. On the top of the atrium, we have the SA node, and it's a normal pacemaker site. Controls our heart rate, depending on what literature or what books you're reading. Anywhere between 60 and 100 beats per minute is the norm. Through the internodal pathways and the atria, it comes to head here at the AV node. Let's see if I can get my laser pointer here to AV node. There's a little bit of pause before the electricity then goes through the ventricles and depolarizes the ventricles. What we look at on a 12 lead or any kind of EKG tracing is that electrical component. And this graphic is a little crude, but it really represents well kind of the 2 mechanisms that we just talked about. Red obviously is the electrical pathways. down below here, you can kind of see how it's represented on the EKG tracing. The top parts is where the atria are actually squeezing or being depolarized. This pause is the pause AV node, and then this complex is the ventricular depolarization. And then there's another pause, and the T wave is formed, and it goes through the you said it's kind of a crude but I really liked kind of the way it was animated when this group put it together, so I use it. We blockages and heart attacks and STEMIs, you know, obviously we have our treatment goals. And I kind of, when I work with the folks here in Wyoming, I relate it to plumbing. Either you're going to have a roto-rooter done or you're going to have Drano given. So it's either a mechanical or a chemical way to get that blockage removed. And obviously, you know, with the guideline recommendations, PCI is still kind of standard with therapies, but you get into those resource-limited areas, it's not always going to be the same available. But basically, the catheters advance through the femoral part, finds the blockage, and it opens it up, inflates the balloon, and then leaves the stents to blood to be restored. We'll find out in this presentation, I really like pictures, so I'm trying to use a lot of them. But with this case, you can see here on the far left, you can see that narrowing of the main arteries that we're looking at on the heart. And next screen over is, you can see the catheter come up from the bottom, and then the balloon is deployed and they're opening up. And then ultimately, you can see the comparison between this slide and then this slide. Not the obvious improved circulation, improved reperfusion, but look how clear these little vessels are off this damage. I mean, there's so much reperfusion restored with this procedure. And really, if we look at systems of care, if we look at our EMS folks, our hospitals coming together to look at and build protocols and do education, this is exactly what we're trying to accomplish right here, this restoration of blood flow. And it's just kind of our goal. I really like this picture, and it shows that before and after. Let's see if my laser point's going to. So as I mentioned, you know, some of the resource-limited areas, PCI capabilities are not as abundant. Our alternatives for reperfusion therapies goes into the fibrinolytics. It's like I said, I think of that Drano. You put it through the IV, and it breaks any kind of blockage. And the fibrinolytic therapy, and with the EMS side of things, when we're doing this, especially in our areas that don't have the PCI capability, is that there's one step further that we're trying to get our folks to do in addition to the 12 lead and their STEMI identification and recognition, but it's to get that fibrinolytic therapy checklist completed. Everything you can do in the pre-hospital environment that will help our hospital friends and colleagues speed up that treatment. We should, and these fibrinolytic therapy checklist is a very but a bunch of yes/no questions, and you know, if you're able to get this done and assist out our hospital friends, that's going to be getting that decision made on administering that drug, or if they're not eligible, we can get transport arranged quicker for interfacility for primary PCI. So our intervention plan for our EMS. First and foremost, we've got to identify our patients that are having this STEMI, and that's based off of acquiring that 12 lead, getting a good interpretation lead, whether it's done in the field or done through transmission by stops at the hospital. But that's our keys. So we're screening our patients as quickly as we can. Notify the information, active life support if you're a big life support service. Nitroglycerin pain control as protocol allows, aspirin, heparin. Some, as I said, the thrombolytic pre-screening is something that we can all start doing. And some services actually are starting to do thrombolytics in the field. You know, we talk about the 4 Ds of stent care, and I think you probably saw this in ACLS class where they talk about decision, or data, decision, and drug. And if we extend that into the pre-hospital environment, I would also throw in diesel. So there's almost 5 Ds of STEMI care. We get them there as quickly as we can. That main goal and what we're talking about today of getting those 12 leads acquired and accomplished, kind of getting into just a little bit of the way those 12-lead machines work. And it comes up to this, and if you've heard the monitor quality versus diagnostic quality of the machine, now the monitor quality. You put your 4 leads or your 5 leads on, and you turn it on, and you're doing that tracing. Well, you're getting a good look at QRS complex, and this is kind of, once again, it's kind of a crude picture, but a very clear look of that QRS complex. You see the baseline, obviously up here right here. You can also see an ST segment, but as you can see this picture, we have it blurred out a little bit because it's just not quite as sensitive point. There's a lot of filters that are in place to where basic monitor quality, you're looking at counting the heart rate, and you're doing a continual monitoring of the heart rate. These other components are there, obviously, but they're not as defined. As you push the button on your monitor to where it says 12 lead, that makes that switch from monitor quality to diagnostic quality. And it basically takes away all these filters that are blocking this out. So it becomes very sensitive to not only the QR complex and the ST segment and the baseline. You can pacemakers. You can see all the other that are acts caused by 60 cycle, skeletal muscle movement, vehicle movement. So when you get into diagnostic quality, there are some steps that we do need to take to make sure that we are going to, once we take away these filters, we're still going to be able to get the best tracing possible. The first one that I like to talk about is, we have a buildup in oil, and when you place the little electrodes on that conductive gel, it can inhibit a bit of that transmission. And so when we look at taking the skin oil, whether it's a quick swipe with a 2x2, an alcohol swab, and you don't have to do the entire, just where the stickers are going to go. Seeing some of the manufacturers, they actually have a little piece of, it's almost like a blue abrasive, I don't want to say sandpaper, but kind of sandpaper. And we'll see actually abrade the skin just a little bit. That takes care of the oils, and it also removes a little bit of that epidermis to where any dirt or whatnot is there. And if you think about it, the electrodes, once they get falling off, are pretty high if you've got somebody that's super sweet, or they've been out in the lake all day or whatever. But we want to make sure we get that skin prepped properly, and it's really as simple as taking, like I said, a 2x2 in one area, maybe followed with an alcohol pad. I use aerosol deodorant and spray the area on the patient's chest, and that kind of helps with remodel that stuff as well. Next area that we want to talk about with skin prep for our patients that have an excessive amount of chest hair, we do get that taken care of. Putting those leads over a patient that has chest hair, you're not going to get a tracing if a tracing actually completed at all. So they have commercial clippers, as you can see here in the picture. It makes it very handy. A couple swipes and just to the area to where you're going to put the stickers again. Is all. But proper skin prep really does help with that concept of all of those filters and the machine extremely sensitive. And it's kind of we're sure we get that done. Other, I mentioned earlier, patient movement. If they're tapping their toe, if they're squeezing the rails too tightly, peeking up to look to see what's going on, any of that movement can actually cause artifacts to appear. Just some simple coaching will suffice. And the fact that the position time of these 12 leads, it's for seconds, 10 to 15 seconds at tops. Explain that to your patient that they need to hold still the button while they get required. The next top artifact we talk about is cable movement. If there's an extreme amount of slack between the patients and the electrodes and the monitor, or if it's too tight, if there's not enough which are actually pulling on the patient, you're going to get some artifact in that way. And one of the practices that we kind of got in the habit of doing is the jump box, if you will, where all the cables are coming in, kind of lay that on the patient's lap. And that seems to take care of the slack between the monitor and the patient, and then you also have enough slack between and that junction box where you're not going to get those leads pulled. Obviously, it's going to cause some artifacts. There's, again, you look at process or protocol. An example that we found that worked out well working with partners is my partner would involve lead on, start the acquiring of while I was doing the history and doing but by the time they got the leads on air button, my partner would walk around to the front of the ambulance and get in, and by the time we were ready to move, that acquisition was completed. Granted, that works great for the initial 12 lead. As to repeat 12 leads, you have to keep in mind that you might have to stop at a stoplight or a stop sign for a couple minutes if you need to get that in trace. Artifact 60 cycle, you get a cell phone near the patient. And this top line here is really a heavy 60 cycle interference. I mean, you cannot do this. There's nothing there. The bottom isn't nearly as bad, but you can see how the baseline is one off or trailing off at the end there. Just think when we look at our 12 lead, to make sure that we have little gaps in between our QRS complexes and a nice clean straight line between our lead views. And we'll get into a few of these examples here in a minute. This you can see is kind of if we look at the baseline here and it's not clean at all, there's a lot of movement, whether it's a sneeze or the patient took a big deep breath or whatever. But this is how sensitive these machines are. We get it into these 12-lead diagnostic quality. I'm going to pick up all of this, and it's going to make it possible to use. And so, like I said, the bottom one here is probably more realistic to what we're going to see. It's a nice, clean, straight baseline. There's a little bit of artifact in between some of these leads, but this is more realistic type lead to what we're going to get in the pre-hospital world. Now, kind of get into lead placement. Where do the stickers go? This is kind of a busy slide, and I apologize. It's a lot of wording, but just to go through it real quick, V1, we have fourth intercostal space right of the sternum. V is the fourth intercostal space left of the sternum. Now, what I typically do when I do my 12 leads, I go to V4 because it's one intercostal space below V2, but we have midclavicular as a landmark. The midfilar line is a landmark. V3 goes in between V2 and V4. The fifth intercostal space, left anterior axillary line, or right at the front of the armpit. And then V6 is the fifth intercostal space, left mid-axillary line, so right in the center of the armpit. And the picture that kind of helps support that. So we have V1 and V2 in the fourth intercostal space, left and right of the sternum. V4 is that midclavicular line, and an intercostal space just below V2. Our basement, right at the front of the armpit, same intercostal space as V5, and then V6 is in the middle of the armpit in that same spot. Hopefully we're familiar with this. Recommendations are wrists and elbows or shoulders and thighs. We want to ensure that they're basically limb leads are not on the torso. And this is kind of exception of a lot of the 70 patients we see are not 150 pounds and appears to be in pretty good shape. But the stickers can get kind of grouped together very easily. And so smaller stature patients, we just have to kind of keep that in mind. Our goal is something like this, a nice clean 12 lead. When I say clean, there's almost zero artifact, if any. The line is good and straight. There's no wing or tailing off. That's really what our goal is. The machines not only print out the lead and they give us the views of the heart, which we'll talk about, they'll actually the algorithms and to do interpretation of the 12 lead. And for the most part, a lot of that is especially if your machine has asterisks in front of it and a statement that is either acute MI suspected or semi-suspected, and then it's followed by another 3 asterisks. That's a pretty good sign that seems spot on, and it's very confident with its interpretation. If you've been around 12 leads, some of these interpretations can be pretty interesting. It's like the machine just kind of goes on tilt. It doesn't know what's going on. And so, I kind of keep in mind that it is a machine trying to do, log, and sometimes it just doesn't work. But what the machine and the 12 lead is very good at and very accurate is measuring. So the 12 lead itself is really a measurement of voltage over time. So if we look where this red circle is, it can measure out the ventricular rate. It can look at the time it takes for the heart of the atria to depolarize. It takes for that electrical impulse to go through the ventricles. It's very, very accurate. If you've done any kind of next level or any deeper 12-lead interpretation, the axis. When we had the beam is it's voltage over time. These little boxes is 0.04 seconds. We're just looking to see how long basically our electricity is going through our heart, if you will. The P, if you remember from that animation before, is when the atria are being depolarized or that electricity is going through there. The QRS complex, and I did not do very good in geometry, so points and just bear with me, but our first pointer is the Q wave, next is the R wave, and then the S wave. We'll look at wave and that segment between the S wave and the T wave, and we'll break those down here in just a second as kind of what our goals are for today's talk. So Q wave, the first negative deflection after the P wave, but it is before the R wave. And so that's kind of where we start with our QRS complex. The following point that we look at, or wave that we look at, is R wave. It's the positive deflection, so it's going above the baseline within the QRS complex. Now, you can have multiple R waves. That's, once again, a little bit more 12-lead interpretation rather than STEMI identification. The next is the S wave. And where we are looking here, and this is kind of the start of our STEMI identification talk wave, where the S wave comes back to the baseline of our complex here. Sorry, the pointer's messing a little bit with my mouse. So our joint to the J point here is what we call the SP segment. So it's a segment that's containing 2 points, right, our S wave in the beginning of our T wave. So our SP segment is what we're going to be looking at. We pair that SP segment to, or for those of you that are really good at geometry, TP segment, look to see if that SP segment is above the baseline or if it's below the baseline. As we look at the evolution of this, you won't always see it, but a lot of times patients that are experiencing the first early stages of a STEMI, the first thing you're going to see is a peaked T wave, like what we hear. Now, a lot of times that peaked wave will be followed by our ST segment, and then as the event goes on, if we don't get the patient to reperfuse, that segment will come back down to the baseline, and then these Q waves will develop. And these Q waves, when we say everybody's got Q waves, but when we say Q waves, we mean prolonged or pronounced Q waves. They become very deep and sometimes very, very wide. And it's indicative of an old heart attack, an old MI. There's some necrosis there. But the evolution of the way that we're going to see these changes, and into a little bit of a practice right now. So these three complexes, bear with me, I know that's kind of a blurry picture. What we want to find find the J points, baseline, and the ST segments. First one, if we look, our point is right there. We'll compare with our baseline and make sure we got a good clean baseline, and it's a double. Then we're going to compare our ST segment, and we'll look to see if it's above the baseline or if it's below the baseline. And with there's no elevation or depression present. Or with the second one, our point is there. So our point and our segment above the baseline. And for it to be considered positive, the elevation has to be one box of elevation. It has to be one box above the baseline. So back of our diagnostic quality mode that we put the in, I mean, it's very, very sensitive. We're looking at a millimeter of graph paper. So it's very, very sensitive. It's very important to do our 12 lead nutrition diagnostic mode. Now, I'm sure anybody else on the phone has done this. We've seen those patients that you can pick up 12 or the ST element on the quality. Those filters still in place. We're going to miss. So kind of box there. No, I'll get off the Dow, I promise. All right, and our third one, our J point is here, our baseline is here, and you see this C segment is depressed or it's below the baseline. And that's really kind of what our goal is where we want to make sure we can acquire a 12 lead that's going to be good and full, for lack of better terms, and then find our J points and see where that ST segment is in relation to the baseline. So the baseline is what's below the baseline. As I mentioned, the elevation has to be one small box in order for significant, and then we call the present and anatomically similar viewing leads. That's kind of how we'll start with the next here. I don't know if you guys have heard of the acronym I see all leads. I did a couple of talks, either a Bob Page talk or a Tim Phelan talk, but kind of helps break down. I learned by acronym, and this really helps. So with the inferior leads, we're looking at T3 and AVF, the sub V1 and V2, the anterior leads V3 and V4, and then the lateral leads V5, V6, lead 1, and AV out. And I get our 12 leads and interpreting 12 leads in this fashion. We look at leads 2, 3, and AVF first, V1 and V2 second, V3 and V4, and then V5, V6, AVF, and 1 following. And the reason why, so with this, you can kind of see it over here. Beer leads are grouped here. All right, 2 AVF are their leads. The septal leads, V1 and V2, and 3 and 4, 5 is for the lateral leads, and then 8 and 1 for the other grouping of the lateral leads. This is where we talk about repetition and doing it over and over again. I like this slide and the way they did it because this little hand card, I've seen a lot of people use this and put it into a badge buddy or some sort of reference card that you can look at. And it helps with being that localization. All right, the interleads leads 2, 3, and AVF. We got the camera angle looking up from the bottom of the foot. We're looking at the inferior wall of the left ventricle. Our groupings will be in this. You can see, looking at 2, 3 AVF as a practice, our J point is right about here. Line is obviously here, and you can see our ST elevation is quite slight. Leads to 3 and AVF are kind of the same. You can see that complex is similar. As we go to our next groupings, V1 and V2, here's V1, are just here. Our base is here, so you can see that actually ST is depressed or below the baseline. Every and V4 is point line, and then the ST segment is below the baseline. When we call these out, I also have it not only just as practice, but when I taught, I would, instead of inferior wall MI, I would say I have ST elevation in leads 2, 3, and AVF. I see depression in V1 and V2, V3, V4, AVL, and 1. Going into IC all leads is our septal leads. So V1 and V2 is going to be our next viewpoint. You can kind of see where the camera angle is looking right there. And if you remember V1 and V2 are fourth intercostal space, right on either side of the breastbone there. On the 12 lead. So 1, 2, 3, and AVF. That first look, V2, you can see obviously our J point is here, our baseline is here, our ST segment and is well above the baseline. If we look before, you can kind of see that that P wave is starting to happen. And so if you remember those, that other side where the evolution of peak T waves is typically followed by the ST segment coming off the baseline, you can see that this is actually starting to extend a little bit into the anterior wall. B5 and B6 are lateral leads, and then 1 and AVL aren't shown. That's the practice that I got into, not only as when I was in working as when I've been teaching as well. I was looking at it in this. And before, looked at the anterior portion of the left ventricle. If you're, just on that last example, you can see that the septal wall leads and the ear wall leads are very, very close together in terms of the areas of the heart they're looking at. And so you see a lot of times attention into other. Remember, in order for it to be considered a septal wall, it has to be continuous in 2 leads. Well, there's 2 leads that look at the septal wall, so we have in only one of those, but still something to watch, and that's just more of a concept type thing that I was trying to get at. But that lateral wall of the left ventricle is a pretty big area. It's got the leads dedicated to it, B5 and B6, 1 and AVL. Once again, it's grouping. B2, 3, and AVF is our first look. Now, as you can see, oh, wait, we have elevation in 2, 3, and AVF. All right, let's B1 and B2. Elevation B1 and B2. Quite a bit in 4, as well as 5 and 6. And then to put in AVL and 1. So there's, you look, and kind of the point with this slide is that if you look just with one grouping and you stop with that one area of the heart that you notice that ST segment elevation, you potentially could miss a very extensive MRI. Continue with that process of looking at those leads in that order. ST elevation for running our STEMI patients, obviously ST elevated MI. You want the elevation to be greater than 1 millimeter, one little box. It's got to be 2 in those two continuous leads looking at the heart and 2 similar leads. Cards are a reference. There's tons of ones. You can make your own, as Larissa made points that these we sent out. If you take one of the references from this slideshow and put it into a little laminated card, by all means, do what you do. How long to get this memorized? I kind of like to think that if I can do it, anybody can. We really want to make sure that we stress, though, that a negative 12 lead, or 12 lead that shows no ST segment changes, does not rule out an MI or a heart attack. They potentially could be having a heart attack, and that's, we look at the majority of our patients that we see actually are present as a non-STEMI or an ST elevated MI. They still could be injury done to their heart. They're just not, you're not seeing it on the 12 lead. Additionally, with that, you have time in the pre-hospital setting to run a second 12 lead on patients that are symptomatic, and kind of that mindset is that if it walks like a duck and talks like a duck, it's until proven otherwise. Well, it's the same thing with a heart attack. Patients that show signs and symptoms that are consistent with a heart attack will proven otherwise. Do another 12 lead because it can change. And this 12 lead is actually from the same patients from our some of our volunteers in South Dakota that wrote this, put this presentation kind of together initially. But as you can look through here, obviously 3 and AVF, don't see a whole lot. B1 and B2, you can see some pretty impressive elevation. B3 and B4, and then you can also see it start to extend into 5. I'm not seeing much in B6 or the other lateral leads. So the patient, the first was taken at 4:06 in the morning. The second one was 12 minutes later, and that this elevation had rescinded back down to the baseline. It works both ways. You could easily flop the time boxes, and this be the first 12 lead, and 12 minutes later you start to see some elevation or see some changes that are pretty significant. So the importance of doing more than one 12 lead, if you have the time on those patients that are symptomatic, highly recommend and getting that completed. Quick on some STEMI part one, STEMI recognition, STEMI identification, some basic background. The monitors are set up, key points with that, make sure that you're utilizing those diagnostic modes, taking time to do the proper skin prep to where you can get good quality 12 leads. Obviously, they're very, very sensitive when in that mode, and we're looking at very small changes that we want to be able to track. Getting your 12 leads placed correctly, those leads placed correctly, once again, utilize the information that's in this presentation, if you'd like, as reference cards, and get your 12 leads on and localize and notify the hospital as quickly as can if something's coming in. Ray Fowler is actually going to be handling part two of our series, and that is for July 25th. I believe we'll be getting, Laura, help me on this, make sure we'll get calendar lights out with times, and all the webinar stuff will be sent here in the very near future. With that, I will kind of get back over to Larissa if we have questions.
Great.
That I can answer anyway.
If anyone has questions, you can go ahead and press *6 to unmute your line. Again, we will be having part two of this webinar series on July 25th. I believe it's going to be at 1 p.m. Central Standard Time, and we'll get a invite everyone when we pull up information from today's webinar. So be on the lookout for that. If anyone has questions, you can press *6 to unmute your line. Were there any questions in the Q&A? Ben?
I have one that is coming up, and it's a great question. And the question of AVR not included in STEMI recognition. And I will be totally honest with you, when we put this together, I was really looked at in terms of making sure we had our lead placement correctly. We always said that make sure we had AVR negative and deflection, but I do know and I do remember seeing that AVR is being utilized with STEMI identification. I don't know what exactly it was, and so I don't have time to put it into this presentation. If there's a physician cardiologist online that would like to take that answer and talk to us about AVR, if you can, that would be fantastic. But didn't really have the opportunity to get it in, so I apologize. But it was a fantastic question, and I'll definitely look it up and make sure it gets sent out. Correct answer for that.
Great, thank you. I'm off mute with *6. Thought I heard the line.
Yeah, this is Eric Stuffel, paramedic with Fort Bend County EMS. I was the one that asked the question of AVR. If you're okay with it, do you mind if I hit on that just a little bit?
Yes, that would be awesome. Thank you. That would be great.
The history on AVR is basically when 12 leads got rolled out to EMS, it was, don't look at it because you're going to look at ST elevation and AVR, and not really ST elevation, kind of like the pulmonary artery vein of the 12 lead, where it's opposite. Elevation is really reverse, and we is depression, and depression should be elevation. The importance of AVR is the fact that it's really looking at the reverse aspect of right off the aorta. So that's obviously a really, really high, can have some major effects, profound effects. So AVR involvement, there's a higher risk that the patient is going to be going to need bypass, or they're going to have difficulty because that is a very large clot. And it's going to globally affect the 12 lead, and some instances, except for the inferior leads, if they're left side dominant. So that's a large piece of AVR's history. It's too confusing. It's the opposite view. Don't look at it. And that was the easy answer when 12 leads were introduced.
Right. Yeah, totally.
And I remember when I was learning 12 leads, I'm like, oh, you want to make it easy? Cool. Yeah, I won't look at it.
Exactly. Block that one out. It's
So now evolved, and we're really taking 12 leads to a new level. And you had a really great presentation. I just wanted to add this to it if possible. The AVR is available. If you have any questions about it, go ahead and do some research on it. Look at it some more. Anybody out there that doesn't know it, because it is an important piece of the global evaluation, especially in involvement and identifying likelihood of arrest, VFib, VTAC, during transport, the need to go to a bypass surgery, or there's going to be a difficult patient. And AVR involvement to a cardiologist tends to speak significant information to them in the report.
Raises like that's great, Eric. I really appreciate you chiming in and adding that, because that's a good question. And now, I got a follow up if that's is AVR like associated, commonly with a certain vessel, whether it's the right or the left, or does it have a coronary artery association?
Typically, and I'll preface with I might be taken out of the realm of my true knowledge. Typically, I found it's LAD association, mainly because if you have AVR involvement, you're going to have lead 1 and then your V leads involved.
Gotcha.
Yeah.
Perfect. Thank you very much.
Okay. Does anyone have a question? A reminder, we'll be emailing the slides and a recording of today's webinar to everyone who registered. That will be out mailbox in a few days. Go ahead.
I'm sorry, did you get my question that I typed on the screen?
Okay, hang on. Sorry. Okay.
You can really if you'd like.
Yeah, go ahead. And I just want to make sure I'm reading the correct one.
One of the questions was, is it greater than or equal to 2 millimeters significance for limb leads and greater than or equal to 1 millimeter for the precordial leads when you're talking about ST elevation? That was one of my questions.
Yeah, I have heard that as well. There's a little bit of difference in the requirements for elevation between limb and precordial leads. Yep.
Then don't you count your ST segment 0.6 seconds beyond the J point rather than at the J point?
I have heard a couple different people talk about, where do we actually start looking at the elevation and how do we track that down? There is some, I don't know, the classes that I listened to, we actually called it the J STEMI instead of just the STEMI, because you look and you want to make sure that higher process or that piece is above and what you're looking at it. But I hadn't heard 0.6 seconds J point. And I'm the first to tell you there's a ton of information that is there, and that's good to know that.
And difference in all of the literature that I've been researching, and I work with cardiology at St. Luke's Medical Center, everything I'm running into is varying between 0.4 and 0.6. I hear difference, but I have had patients here at the hospital that if you counted at the J point, they're not having a STEMI. But if you counted at 0.6 beyond when they're having ST elevation, that will make the difference, and they end up being called a STEMI and go to the cath lab here. So that's why I was asking about that.
Interesting. And I don't know, and I'll throw this out kind of for discussion, especially for that. Do you see that there could that variance, with protocol process changes that are based off, for the facilities that for physicians, but we all know that there's some physicians out there that are not quite as up to speed on the most current recommendations and guidelines. Do you think that could be one of those instances that we just haven't heard that yet? Or it's in all the areas that hasn't been common practice, common knowledge. It's great information. It makes total sense. If you think about, if you look right at that J point, it could have that slope up of the ST segment, and there's a portion of it that's below the 1 millimeter, and then it's above, and it makes sense. Makes total sense.
On of your beginning, when you're talking about baseline, some saying before the P wave, some saying after. Experience on that?
So just when, kind of the isoelectric line. So as it's kind of what I was looking at with, that pause at the AV node after the P wave. It's, there's that period where there's no activity. It's just, so just the isoelectric line is what I was getting at.
Okay, yeah. Thanks.
Great questions. I couldn't answer them better there.
You did a
Thanks.
Any questions? Star 6 to end the line.
As a little footnote, this is one of the favorite things. This is why when I worked as a paramedic, ecology was my favorite subject, because it doesn't matter or how much there's always going to be something new, and it always makes a great discussion. And I'm just walking away today, going to probably go check AVR and take a look at looking at that J point, or that 0.6 seconds past the J point. I mean, this is fantastic. And so if there's folks that are on the phone that are relatively new to 12 utilization and 12 lead acquisition, standing recognition, I will say this, it may seem overwhelming, but it's one of those areas that you will never, it's just so much information, and it's always changing, and it's always great to get into these discussions, and never be afraid to ask questions, and seek out any of your colleagues for input. So it's my favorite subjects when I was, like I said, when I was a medic and going through school and beyond. So I highly encourage try to get encouraged and try not to become too overwhelmed, because it is easy to do, but just it's a challenge, and it's learning new things and building your base. So I appreciate everybody's time on today, and I'll kick it back over to Larissa for.
Yeah, we'll go ahead and wrap up today if there are no other questions, and I will be sending the slides, the recording, and then the information for part 2 of our series on July 25th, I believe at 1 p.m. Central. So when attending that, thank you so much, and thank you, Ben, so much for sharing your knowledge today.
Yeah, thank you.
There you go.